I think we can now try to switch.
We have first lab is ready.
Yeah, okay. We can go to the lab and see in live 2 cases. One will be or should be neuroablation, as was discussed today, and the other should be this strategy, endocardial strategy for inappropriate sinus tachycardia. So I think Dan should handle the case of inappropriate sinus tachycardia. As you see, he's already in the lab with our colleague Peter Šťavnický, and they work together. So they will show us what they have done so far and what they will do.
So hello everybody. Can you hear me?
Yeah.
All right, perfect.
Yeah, we can.
So, all right, perfect. So we will start with maybe introduction of patients.
Okay. In this live case, we are going to focus on pulsed electric field ablation for inappropriate sinus tachycardia. Please, next slide. This case report is about a female, 42 years old, with hereditary dilated cardiomyopathy with titin gene mutation, documented normal ejection fraction, and no sudden cardiac death in family history. This patient was implanted primary preventive dual chamber ICD a year ago, and this patient suffers from multiple inadequate ICD shocks, a total of 12 shocks since implantation, mainly in stress and during exercise, and all despite beta blockers and ivabradine in chronic medication. Next slide. This is baseline ECG of patient with normal sinus rhythm and heart rate about 85 beats per minute. Next slide. And these 2 pictures demonstrates heart rate trend and heart rate histogram from ICD. Average heart rate is about 91 beats per minute and max heart rate 180 beats per minute. Next slide. And what is scheduled in this procedure? SA node modification by pulse field electric field ablation using Thermocool SmartTouch catheter and PF galvanized system, 3D navigation by CARTO and facilitated by ICE, and the procedure will be performed in general anesthesia. Our procedural endpoints will be superior vena cava isolation, serial intercava lines, and sinus slowing and transient junctional rhythm. Next slide.
And I will continue just because this is completely new concept. I will try to give you some background, our experience, and I will show you some images from our previous procedures. We have very limited experience. We did 2 cases so far at the end of the last year and 1 in the January this year. Next slide, please. So on the left-hand side, this is the figure you probably have seen already in the presentation of Carlo Asmundis. This is the proposed lesion set during the thoracoscopic surgical sinus nodal modification, sinus nodal sparing ablation for inappropriate sinus tachycardia. And on the right side, this is CARTO map of what we try to reproduce by using pulse field energy, because there are 2 benefits, at least 2 benefits of pulse field energy. First, there is no risk or almost no risk of creating the phrenic nerve damage compared to when this modification is done by radio frequency in past years, which was almost abandoned, this radio frequency procedure. And the second benefit, in my view, in my opinion, is that this pulse field ablation caused only temporary suppression of vagal innervation to sinus node, because this effect is always associated with radio frequency ablation and definitely is counterproductive during ablation, because you do 2 things. First, you try to cut off sinus node from all sides to decrease its intrinsic its intrinsic frequency, and at the same time you denervate significantly by radio frequency the node. So it goes against each other. So this is the first benefit or second benefit of a pulse field, and the third benefit might be that we are able to go deeper with our lesions, because it is well known that sinus nodal ablation is very difficult, because the upper part of sinus node is more or less more epicardial structure than endocardial, and it is localized at the level of superior crista terminalis. And at this region, the thickness of right atrium is not so thin. So in roughly half, 50% of patients, it is even after repeated attempts to ablate the sinus node endocardially, it is not possible, and epicardial approach is needed. And we believe that we are able to penetrate with energy deeper than with radio frequency, especially when we are not limited by the presence of, for example, phrenic nerve. Next slide. So this is what we done so far in these two cases already performed. We map right atrium and remap the sinus electroanatomically by activation mapping. First, like a native activation, and this is this yellow point. And on the right-hand side, this panel shows how it moves up and anterior during isoprel infusion, 3 micrograms per minute. And so we have two points like that annotating plus minus the site of sinus node. Of course, these are endocardial breakthrough, and we don't know exactly where the sinus node is. It is not possible to localize it exactly by endocardial mapping, but at least to have something. And you see that during isoprel infusion, the airless activity is superior to the ostium or junction of SVC right atrium. So what we did next is that we started with, next slide please. We started with superior vena cava isolation. We don't care about phrenic nerve lesion. In fact, we may create some temporal lesion, but it recovers in minutes, or at the latest at the end of the procedure. So this is the first step, and this has no was not now first procedure. There was no effect on sinus node rate, even if we isolated completely the most active, the most superior part of sinus node. So there was no effect, and then we continued with some. Just to reproduce the surgical lesions, we created a series of intercable lines, and we started rather posteriorly. This is the first slide on the left side. We started rather away from the center of the native sinus node, because at that time we had no experience. And I believe that there will be no effect, but the opposite was true, because when we started cranially and went to IVC down, and when we reached the upper third of this ablation line, we had sudden sinus rate slowing, and we continued down, and when we were very at the bottom of the very distant from sinus node, there was a short episode of junctionalism. But it resolved in a couple of minutes, and of course, sinus rate was a bit slower, but not so. The drop was not so huge. So I can't view my monitor. I lost the signal completely. Yeah, I'm sorry. I can see again. And so, because there was not enough drop-off in sinus rate, we continued the second line, and there was no effect at all. And we continued with, again, you see on the right-hand panel, you see the third incomplete line, and there was no additional effect. But during the infusion of isoprel of 3 milligrams, 3 micrograms per minute, there was sinus was significantly slower. Let's say we started at 130 per minute or 135, and we end up with 100 approximately, and it went even lower when we stop this infusion. So this is exactly what we did during the first case, and we will try to reproduce this lesion set today. I think this is enough from this EP room, and we may switch if you have any questions, of course, you may ask, but otherwise we are ready to switch to cardio-neuroablation guys.
Okay, so I say thanks for introduction, for this, let's say, suggestion how you will do the case, and we will follow you in next entry to your lab, and we can switch to Roman to see how they proceed with neuroablation in a typical case of patient with neurally mediated syncope.
Okay, do you hear us?
Yes.
Yes. Okay, so greetings from ECAM.
It's better.
Can we put volume down here because we don't hear ourselves. Okay, so today we are here with Dr. Piotrowski. We will present a case and show you the case of cardio-neuroablation for cardio-inhibitory syncopes. This we have here a 29 years old female patient without comorbidities, without structural heart disease. She had a repeated syncope since childhood, and that's the reason why epilepsy was suspected but not confirmed. And these syncopes were with typical vasovagal prodromes, with vomiting, and a higher degree AV block was documented with 20 seconds asystole. Can we show the next slide? So this is one of the episodes documented on the Holter ECG, and here you can see the asystole because of the AV block, but you can notice how the P waves are speeding up. So this is probably some compensatory sinus node acceleration. Can we show the next slide? This is her ECG on admission. We are doing atropine test in those patients just to prove that this block or this asystole is caused by reflex, not by intrinsic dysfunction of the sinus of AV node. And here you can see that baseline she had 74 beats per minute, and in 5th minute after the full vagolytic dose of atropine, she had a heart rate acceleration to 140, so the acceleration was 40 beats per minute, which is a 65% of the baseline heart rate. And you also can notice that there is also a shortening of the PQ from 156 to 142, which is typical for a reflex dysfunction of the AV node. Can we show the next slide? And this is what we plan for today. This will be the radiofrequency catheter ablation in general anesthesia, because we will use the extracardiac vagal nerve stimulation that offers us the clear endpoint of the procedure. And this procedure will be 3D navigated and facilitated by intracardiac ultrasound, and we will also, Roman will show you the ultrasound visualization of the vagal nerve for extracardiac vagal nerve stimulation. And I will just show you what we have so far, the maps. I don't know if you see the cartomaps. Můžeme ukázat? Yeah. So we did basically just anatomy of the left atrium and the right atrium. We tagged the phrenic nerve. We did an activation remap of the sinus node just to know where is the breakthrough, and we tagged the hotspots for the sinus node denervation and for the AV node denervation. It's a purple point in the left atrium. And we also did a baseline EP study that showed normal SNRT interval, normal Wenckebach, and normal AV nerve. So we also performed the extracardiac vagal nerve stimulation the way that we are doing in ECAM, and Roman will show you the his way. So let's show the stimulation, please. Review. Can we show a review? And first we did no, that was not the first. RVPP. Saro, can you take this, please? RVPP 1.1. Okay, so we paced from our typical spot, and there was a very poor response in terms of the sinus node and AV node reaction. That was atypical because we also paced from the left vagal nerve. Can we show the left vagal nerve stimulation? And there was a pure, very nice sinus arrest, and also during stimulation, please. Show them. And also during the stimulation, there was a long AV pause. So with our approach, we were not able to make a big pause on the right side. So Roman will show you how we deal with this.
Yeah, so we have our angiologist. So now we will show you how we find the vagus nerve, the cause of the vagus nerve, and Anna will show you typical view from the on the right vagus nerve. And from this point, as you can see, this ECVS from the right vagus under ultrasound. Now?
Yes.
Can you show? So the vagal response was much better than from the higher place. And Anna, could you tell us what do you see?
Basically, maybe.
Okay.
Yes.
Can we see intracardiac echo? We see
no, because we are switched on to the ultrasound.
Yeah. We see just static. Okay.
Yeah. Here.
Okay.
Okay. As you can see, the cervical tract of the vagus nerve is in the carotid sheath. It is between the internal jugular vein and common carotid artery. This is a small oval structure that is hypoechoic inside and hyperechoic peripherally, and it is very important to distinguish it between the small vessel. If you have any problems, please use the color Doppler with the small velocity values to distinguish the nerve between the small vessel. This is the transverse plane, and this is the best plane to visualize the vagus nerve because, as you can see, we can see the whole cross-section area, all of the structures, the vein, the nerve, and the artery.
Okay, so that's typical view for vagus nerve. So Predrag placed the catheter in the place when the catheter was very close to the vagus nerve, and pacing from that, as ECVS showed that excellent vagal response.
Can we show the catheter on the ultrasound? On the ultrasound?
Which one? Is
in
the right?
Visualize the catheter on the vagus nerve. Yeah, this.
Oh, okay.
Show them.
This is from the right? In the right?
Or this is in the right. Yes.
Okay.
It's actually very low position compared to our. Here you have.
Here.
On the left.
Okay.
It's just above the.
Okay.
The
Can
valve.
you show us, Anna, vagus? Okay.
So basically, I can show on the. I cannot show like this. The vagal nerve should be in the sulcus between the vein and artery. on the posterior part, and Roman is now trying to put the catheter.
Okay.
Yes, yes, yes.
Yeah.
Great, great. And can we see the long axis view as well? Yes, great.
And
great.
you can see a good contact between tissue and the catheter also touch the vagus nerve, which is below the wall of the vein. So we can also pace now from the right.
I'll just store this because this is a very nice view. Great.
Yeah, can we do ECVS?
Můžeme stimulovat vagal nerve stimulation, please.
Can we see live screen, please?
Live screen. Wait,
Yeah, yeah.
wait with stimulation. Show the live screen.
Yeah, can you see?
Yeah, but just small. We don't need to see
Yeah, the big one
anymore.
So, okay.
Echo. Okay.
Okay, so
Okay.
let's pace.
Let's go. Yeah, great.
Yeah,
Great.
and we have some bradycardia and sinus arrest and also atrioventricular block. So 3 in all.
Nice.
So can we change ultrasound to eyes?
Můžeme přepnout eyes, holky.
So Predrag do everything what I want. So I think there is from my side it's just burn. Because the patient has purely AV block, so I would like to try avoid sinus tachycardia. So I should focus on the lower ganglia. As you can see now on the eyes, there is a triangle between right of left atrium. So let's do ablate. Could you PA give me?
I'll show you on the eyes. Okay.
Yeah.
So, if I understand,
So again,
you will focus mainly on this input to AV node and neural input.
Yeah, I would
not,
try to
not
do it, but
to
sometimes
sinus
it's
node?
impossible. No, I wouldn't touch the sinus node because the patient is young and I would avoid to sinus tachycardia in the future. But sometimes it's impossible, and I hope that it couldn't. But sometimes I have to burn also the higher ganglia.
Okay.
If I may comment, just take a look on this ICE. ICE is very useful tool also for all kinds of the procedures, including cardioneural ablation, because we can visualize the catheter on this pyramidal space that is very important for the denervation of the AV node. So Roman will has a pretty much the same approach as Dan, so he will burn from all sides,
Yeah,
right?
yeah.
From the left atrium, from the right atrium, and also from the CS.
Yeah,
So now we can see how that catheter touch. There is a good contact on the triangle. Predrag will show you.
We have so many catheters in the right
Yeah.
atrium, so sometimes it's shadowing from all sides.
Yeah, but
I think you
okay,
need,
here.
Yeah.
Can you see? Well,
yeah, yes, this
The
is the
catheter-
left side of the pyramid.
Yeah,
space,
this is
and
from the
then,
left
then you
side,
go
so-
from right side and then from floor of
yeah,
coronary
exactly.
sinus osteum. So
Yeah,
this is this
exactly.
triangle, or pyramid, which was described by.
And then
by
if it's
Dan.
not enough for to
Last year we
obtain the
called that
nervation, so
Victor
we are
pyramid.
going to the extent ablation. So let's we can burn. So let's burn.
We have 10 grams.
The force is 7 to 10 grams, and I think the settings 35 watts and up to 500 of ablation index.
So the beauty of
So we can
extracardiac
burn.
vagal stimulation is after every burn you can check and you see
Yeah, we
the
can
degree
check.
of
Yeah,
denervation,
exactly.
which is to me it's a clear endpoint.
now
It's
this is
something
perfect.
completely different from things that you do something and then you expect that there will be effect. But here you can measure, you can assess after every application, you can assess the effect.
And one very important thing, usually this sweet point for the AV node denervation is in the middle of the this space between the annulus and the right inferior pulmonary vein. So again, ice is useful to tag these important points, and this point is usually in the middle.
Yeah.
Sometimes you have to go a little bit higher, a little bit lower, but it's somewhere here.
Again, emphasizing the role of intracardiac echo for complex CP procedures.
It's not very close to right inferior pulmonary vein. Okay, so we can burn, yeah, it's burned.
Can argue with this.
How many watts do you want?
35 and up to 500.
Okay, 35 watts ablation here, please. This is okay.
Yeah.
Okay,
yeah,
let's go.
contact is good. So.
Go.
Bubble.
What's happened?
So you see.
Okay, we have some technical
problem.
Problems with the
ablator stop.
It's more or less as described between this fossa ovalis and right inferior pulmonary vein. If you rotate more, you will see right inferior pulmonary vein, which
here are left veins,
is a target
and if I rotate more,
PVI.
This is right inferior and this is right superior. Yeah. Usually when you see the pulmonary artery behind, it means that this is superior vein. This is inferior, and this is a basically skinny lady.
We don't see now ice.
Yes. You don't see ice. Sorry.
You can do it again in the meantime, so just to show.
Okay.
We see a left vein, esophagus, right inferior vein on left side, and now superior vein, and next to it is a pulmonary artery. So that's a typical view. This is, this funnel shape, superior vein, and the inferior vein is on left side. So it's very close to that area where we are now.
You see appendage here.
With the ablation catheter, you see we're just below the attachment of the fossa ovalis or the lower part of the fossa ovalis.
Again, appendage
These
from the short axis. You
left
can
veins again,
see also the left main.
Appendage. And the ridge between appendage and left vein, we emphasized yesterday how important it is to display and properly manipulate any tool which is intended to do a PV isolation on left side, because left side is more anatomically difficult than right side.
Are you okay with the position?
I think, yeah, it's good.
Okay, let's ablate here, 35 watts.
Any questions?
Tilt this map up, please, a little bit. Tilt it up, yes.
Can we switch to a left catheter to perform ECVS to check?
500 ablation index.
Yeah,
yes.
500.
So they are delivering now, guided by ablation index, because we use smart touch.
Stop. So let's check.
Let's check
from the left side.
From the left side, because the response. I will just check if we still have the same position. Okay, we need to switch to this one.
So as you can appreciate, this is basically anatomically guided procedure in a way to see where is the ganglionic plexus or plexi. As you know, that there have been several strategies suggested, like high frequency stimulation on site of the ganglionic plexi, or some people try to image with MIBG. We did also in the past, so you see still the reaction is preserved. This is probably very difficult to display with imaging ganglionic plexi, but some people believe that if you have some fragmentation in some areas, so you can do even high frequency, or you can do spectral analysis of these high frequency potentials. So it can give you some so-called AF nests. That's an invention of Dr. Pashon, who also invented neuroablation, or described first neuroablation. So everybody does it in different way at the end. Basically, you can go anatomically because we know where is the location of this ganglion plexi. And if you use extracardiac vagal stimulation, it gives you immediate feedback that you are destroying these ganglionic plexi. So that's the alternative way to really localize ganglionic plexi based on some stimulation on site. So since we did some studies in the past with Dan during AFib ablation, and we tried to modify also, we believed that maybe it will improve results of AF ablation. So all this knowledge which is now used for neuroablation has been already accumulated before, so it doesn't come from the blue. It has a lot of preparatory work behind, you know, to localize these ganglion. We also work with Hiroshi Nakagawa, who is one of the proponents of this adjuvant effect of GP ablation on AF ablation efficacy. But now it's also very interesting clinical trial, or let's say clinical study, or we can do clinical studies with thermal energies versus PFA, because PFA, as already said, does not harm nerves compared to thermal energies. And there is one randomized trial which is called BEAT-AF. This is a European grant which is administered through Bordeaux. And both our centers are part of this study, and that's a randomized comparison of pulse field ablation with Farapulse technology versus state-of-the-art smart touch with contact force sensing, point-by-point ablation. And the beauty of this study is that there is a sub-study which is run in Prague in both our centers, and we have, I think, more than 100 patients who have, during these ablations, they have extracardiac vagal stimulation. So we know exactly that these patients had or did not have this GP ablation. And we will correlate with a clinical result, obviously, because this is a study with a follow-up, and we follow these patients, and we will see how many patients do have or do not have recurrences of atrial fibrillation. So I think this is a very nice example of clinical trial, which can give us more answers about the role of GP ablation for effect of AFib ablation. And so based on our preliminary experience, I think looks that if you really isolate very durably pulmonary veins and you do lines which are also durable, or you completely erase posterior wall, it probably is more important than GP ablation for AFib recurrence or no recurrence. But we have to see. But this is an example how we can now use a pulse field together with extracardiac vagal stimulation, and together compare with thermal energies, and to give us more answers about the role of GP ablation for AFib ablation. So sorry guys, I was just, because we had some troubles with delivery, so I was just talking a little bit about some studies.
But still, okay.
Where you see that they are testing, after applications, they are testing again with extracardiac vagal stimulation, and you see that there is still a response of vagus. So there is a more need for more ablation. So to me, this is a clear endpoint. Whenever you have such an endpoint, you can really guide your procedure with repeated stimulation, which is always much better than if you don't have a clear endpoint.
Can we show you one more thing?
Yeah, sure.
Very interesting. We need to show them Pruka review screen, yes, please. And this is something that Dan Wichter showed me, that because some operators are guided by these fractionated signals. They think that GPs are the areas of these fractionations.
Yeah.
And we have a signal from the... Oh, you mentioned that. Okay, but we will just show you the signal. Let's show the signal from the...
Probably go to higher speed, yeah?
Higher speed. Na začátku to bylo, Sáro, prosím tě, ten signál, tu fragmentaci. Yes. So these are very fragmented signals from the sweet spot for the denervation of the sinus node. And you can see that there is one ectopy, and you see that at the same spot, the signal was completely different. Yeah. And this is not because our catheter moved, because we also paced from the difference from the lateral side of the left atrium and show them the signal. And you see this signal is completely different, so it really depends on the activation sequence, if it's going from the septal, from the lateral side. So we believe that fragmented signals are not the pure sign of the
fragmented the presence of fragmented signal at when you use a bipolar catheter, bipolar recording is dependent on activation wavefront, and you just change activation wavefront, you have completely different signal at spot. So we never believed that this is a right way to identify GPs, and Dan did some studies on this. I don't remember exactly what he did, but I think he compared the different stimulation side, but we don't believe that this is a really you are able to identify these spots. But we did also studies with high frequency stimulation at these areas, and then obviously when you create this vagal response again, you can expect that there is a GP. But it's cumbersome to stimulate all these spots. But because they are anatomically located more or less in the similar areas, you can do this empirical anatomically guided ablation. But you can do this extra cardiac vagal stimulation as your let's say identification of this, because you confirm if you ablate and you completely abolish the response, you probably destroy the GP. So you don't need to search with high frequency stimulation for GPs, but you can check with high frequency stimulation in this vagus area as shown nicely. So everybody understands now the concept, because sometimes people are mixing up extra cardiac vagal stimulation with stimulation on site, you know. So this is completely different thing. And we also try to, we bought in the past this gamma camera, this segmental gamma camera. We try to display with MIBG, it's completely non-reproducible. But it showed us some areas which we then later used for this ablation. So every experience is nice, because you always learn something. Although it looks that it was a waste of time, but always you learn something, either good or bad.
Also, one more advantage of using ice for the selecting of the right spot for the transeptal puncture. This is also very important. This can save your time and your nerves.
Okay, so let's check.
Okay, let's check here.
During pacing from CS.
I like that, but I think we have to go to the CS on the other side.
Yeah, this was a good comment, and I think we repeated that several times during this meeting, that intracardiac echo really gives you power to display what you want to display, to do things that you otherwise do just by chance. And here you can do selective puncture. You want to do low puncture, high puncture, anterior, posterior, so you can really be selective. If you do it just with X-ray, you are happy that you go through, but I agree that you can go with experience, but you never can be so selective as with ICE guidance, and you never can be so safe, because you know exactly what you are doing. But this is just one part of using ICE, as we could see in the repeated examples. So, and as I said during our VT case with Pascal, and he actually agreed, because in US, everybody uses ICE, but in Europe, people always tell me, oh, it's too expensive, we cannot use it. But then they use all these multipolar catheters, and they use pre-recorded CT scans and segmented, which costs also money. So if you sacrifice all these things which are not so important, maybe, because you can do procedure also without them, and you can save money for ICE, you can do. It's just an excuse for people who don't want to use ICE. So think about. And once you start to use ice, you learn so much that you will not abandon this, and you will sacrifice rather multiple signals compared to visualization of structures and your catheter and your puncture site and other advantages which intracardiac echo is really bringing to your lab.
When we have a time, I understand they have some pause. So would you stress the need for eyes plus 4D? Means like two-dimensional, three-dimensional.
There is obviously development of
technology that's going, and actually,
but
I
think
would you
that
say some profitable comments about this, or?
I don't think it's so important today for us, for EP, because we work typically with either with just like a single-shot device where you don't need a mapping system. If you have visualization, as we showed yesterday, you can visualize your PVs, and then you can properly attach your system to the ostium. Or you work with 3D navigation, so you don't need this 4D or 3D echo as much as, for instance, structural heart disease people who do appendage closure or some other interventions. For them, it would be a big advantage. But I think for EPs, 2D echo is fair enough, and we believe that if companies will produce more of these, there will be more competition and the price will go down. Then this is what we need. I don't need 4D echo for my EP procedures. There is no need for that. I mean, you just rotate the probe or you bend the probe, and you can follow all what you need. So
actually, for appendage closure, it's like not an ablation topic, but for appendage closure is like maybe very useful.
Yeah, okay. That's what I said. I said for interventions, but not for EP.
Okay, so in the second lab, they are ready for us. Okay. So maybe we can switch to other lab, Predrag.
So we let you work, and then we switch to the other lab, and you come back, okay? Or you have something to show?
Can we show the effect of ablation, please?
Okay.
No.
Okay, so
show us the effect.
More ablation from the right side and also from the coronary sinus ostium, and this was the review screen, please. Yeah.
And you can see the effect. So that was a selective AV node denervation.
Yeah. So you see that there is a complete loss of responsiveness of the AV node to extracardiac.
But you did just, when I followed, you did ablation in coronary ostium mostly, huh?
So you did
and also on this pyramidal space from the right atrium.
Okay.
But maybe put the catheter just to see where it was.
So Roman, this will be for you endpoint? For this lady?
Yeah, I would be.
I think it's
an excellent endpoint because we avoid sinus node denervation. The patient will not have a sinus tachycardia, and we tailored the procedure for the patients.
Okay, so
for me, it's excellent result.
Any question to this team?
Good job.
They want to see Carto screen, please. Can you put Carto?
So we just ablate one ganglia and pyramidal, and as you can see, there was maybe 5, maybe 6 applications.
So you see, they are all from different sites. Like if you are ablating in summit area, you also have to go from different sites to map and maybe ablate sometimes.
I am afraid of reinnervation, so.
Yeah. So this is not finished. Basically, we want to go to the CS and to do more applications against this region from the CS.
Any question? How you pace vagus? It's a high frequency, high energy stimulation from this off-label simulator, but as Dan mentioned, that there are some companies which produce, and they will be producing probably this because this will be more widespread use of neuroablation. So that's so far the problem, because it's not available for everybody at the moment. Or maybe if you search, really, you can get one. But we use this Passion simulator, which he when he showed this first case here in 2015, he gave us this one, and we use it. It was a gift.
I think at room 3 they are prepared. So if you want to go there, we will just finish few more applications from the CS, and and then we can come back.
Okay, great. So we will follow what Dan did in the other lab with inappropriate sinus tachycardia. Dan, no?
Dan?
Ano?
Can you hear us?
I can hear you.
So we
can you hear me?
Ready for you.
Can I start speaking something, or?
No, it's yours now.
All right. So we already did some ablation, but prior to ablation, we did some investigation, and I will try to show this what we done. First, you already have seen that we did the activation map of native sinus, and then we started infusion of isoprel, 3 micrograms per minute, and we did the second activation map of sinus. And this is what you currently see, and there was a shift
up.
superior, anterior by more than 8 millimeters, and it is annotated by the second yellow point. So we have 2 sinus, let's say sinus points that are 8 millimeters away, and you see that this superior point is behind the superior vena cava right atrium ostium, which is annotated by these circular white points. So that's all. And we continued with this isoprel infusion, which accelerated the sinus rate from 70 to 115. And now we switched to ablation map already. And please show this from more from posterior. We slightly to the left. We avoided so far we avoided the area of phrenic nerves, because we want to demonstrate this live, and we started ablation more septally. Rotate trošku doprava. All right. So we started somewhere here. All these sites were already ablated by 25 amps by by Centauri ablation system, and what is important that this violet point I'm pointing to is the site. This is sweet spot for sinus nodal denervation when we do cardioneuroablation. And when we did these 3 lesions here, which we changed from standard ablation color to this light red, we observed acceleration of sinus from 115 to 150. Because there is temporary sinus nodal denervation, which goes against the what we want to achieve during the procedure. But fortunately, it is temporary, because when you look at our live Pruka screen, you see that our sinus rate is only 93. So there was 70 beats per minute, it was the baseline rate. After isoprel, it was 115. After ablation of these spots, we accelerated to 150, and we continued ablation around ostium of SVC. Go, more go, and please remove the appendage, not to interfere with the nice view of this. All right, so we finished almost the full circle, and the sinus node slowly dropped from this 150 back to 115, which was the baseline rate on isoprel, and now it is even lower. And why we didn't finish this phrenic segment lesion? This is what we want to show just now. When we did this lesion, I believe that there is still no phrenic alteration. But when we start pacing the phrenic side superior to the lesion, there was acute non-capture. So even if you ablate rather distant from the phrenic by this lesion that you can see, there is a gap. I guess it's 1.5 centimeters, and there was temporary non-capture of diaphragm. Maybe it lasted maybe 5 minutes, and now there is full recovery. If you want to see this, maybe I will. Helena, please start pacing from ablation, and when we achieve the capture of phrenic, I will show you. I will go for 10 frames per second, and I will show you fluoro just to see that there is. You see the phrenic capture? Yes, is it clear? I don't know. Can you see? You can't see. You can't see. Yeah, show fluoro, please.
Okay.
Yeah. So again, we are pacing phrenic. That is, we feel and see phrenic capture, and I will show you I show for you fluoro. Yeah, phrenic capture. It's clear. All right. Stop pacing, please. And now we finish the line, circular line, to achieve the SVC isolation. And I am sure that after a couple of lesions directly against phrenic, there will be definite loss of capture. Maybe it will be longer, not 5 minutes. Maybe it will be 20 minutes or even longer. I don't know. But it should be done. So please. And one more thing, you have heard from Peter Peichler that there is an issue with these proximal rings that are displayed on the when you see the shaft of the Navistar catheter, you see one ring. The one is close to the IVC, the second one is somewhere in the middle of the right atrium, and there is some leak of pulse field energy. But now we don't care because these rings are not in touch with myocardium, and if we want to be on safe side, we may advance SR0 sheet just to protect and make these rings fully isolated. But this is not issue in this case because it may.
Left ventricle retrogradely, you have to be careful because these are sitting just at the level of his bundle, so you can create
exactly.
a temporary block, complete heart block.
All right, so just if you rotate the map, you will see that these rings are away from the myocardium. Yeah, go, more. It's not, maybe, if it is touched somewhere here in lateral right atrium, it doesn't matter because it's maybe for conduction system it's important, but just to be on safe side, now I will move the sheath higher, so now it is protected. These rings are protected by long sheaths, and we will. Když tak mě vyhoď ten dlouhý šít, já už tam nechci vidět. No.
You see again intracardiac echo.
So we go for
where is the crista terminal, where is the sulcus terminalis, where is your ablation catheter, where is the contact with the tissue, so you can really rely on real-time anatomy. Not this is virtual reality, but this is reality. So you see everything. You control the situation. Again, I explain because people don't believe. They all the time demand some randomized study data, but I don't want to randomize my patients because I know already what I can get from intracardiac echo. I don't want to. I believe it will be unfair to expose half of my patients for somebody who does not believe, just to increase the risk of any complication or failure of the procedure because somebody wants to see what is obvious. If you're seeing all these structures, it must be better than if you do it blindly, more or less.
No tak ale ať ještě chvíli vydrží, protože mi tady tohle...
But that's my personal view.
Aspoň to tady kousek ukážeme. Dobrý. All right, so if I may continue, now I am ready for direct hit of phrenic because we are exactly against. So so take a point here because there is loss of view of catheter during the Centauri system delivery. Now we are applying energy for a couple of seconds. So we take a cartotac prior to delivery because we are out of control for a couple of seconds. Now I am waiting for when the catheter will come back to the 3D map. It is there. The lesion here is ready, and I just want to demonstrate that if I go superior, I position the mapping catheter exactly at the clear capture sites that were annotated at the beginning of the procedure, and now start pacing 20 amps. Is there? No. Yeah. I will show. I'm waiting. I'm waiting for, and I will show you the flora. So you will see diaphragm is not moving, not jumping. All right. So we have acute phrenic lesion, but hopefully it should recover in not 5 minutes, but maybe 10 minutes, 20 minutes, or a couple of hours.
Obviously, if you want to isolate this SVC with RF, you have very high risk that you can damage permanently, or with cryo, that you damage permanently the phrenic nerve. So that's the rationale behind using this pulse field lesions in this area.
Can I have a comment, Dan and Joseph? My personal experience with galvanized system is a little bit problematic because, as you know, might know, that the very first and very unique esophageal lesion by PFA was only done by galvanized system, which means that the PFA you deliver through the catheter is not like trivial. It's not like non-thermal. We know all that PFA is still some kind of thermal, but not so like ablative thermal. So it shouldn't be active, okay, in terms of thermal effect. So can you stress that you are really sure that Centauri, this kind of generator, gives you which kind of energy to the catheter?
Well, I think there is no doubt what kind of energy it delivers, but as I said yesterday, it has to be tested repeatedly, and you have to have safety profiles because every technology is different, every generator has different pulse field characteristics, and there is no way to test something during the case or change something during the case. You can in this generator you can increase or decrease the level of energy.
This is not only the problem of generator. This generator used is in different catheters.
Yeah, that's of course.
And this is main limitation in perception test or not test, because you cannot test just with 3 catheters.
Yeah, but you can increase or decrease the level of energy in this type of generator.
If you use Afera for this same position and you get a pulse, you never get this kind of phrenic pulse. That's my point. Okay. So take-home message is the same as Pepa is saying, but actually you be careful. And it's not trivial that galvanized product really or cause real thermal effect on esophagus. Okay.
We are not using it here for esophagus or close to esophagus.
No, it's saying something. Okay.
Questions?
It's the problem of the system.
Yeah, because there is interference with Cartos. So
actually, its disappearance is because they have a switch. So you need to switch off, because by the delivery you can damage the things, right?
So also could freeze intracardiac echo image if you deliver. So it's a high voltage, where you deliver.
Can I say a couple of words before we switch to other EP room? They want already wrap up because they are at the end. So I just want to comment what we did now. We finalized the circle around superior vena cava right atrium junction with the hopefully temporary phrenic lesion. And now we checked if there is really clear non-capture inside, like behind the circle. When you rotate to the left. So there is a black point. This was a point with nice, as we see, electrogram with nice capture prior to ablation. Now you see here kind of far field from the right atrium. And when we start pacing from the ablation catheter, there is no interference with sinus rhythm. So SVC is isolated, and we probably also, we definitely isolated the upper part of sinus node, which was annotated while we infused the Isuprel 3 micrograms per minute. And now we will continue. Our frequency is now 83, so it goes down and down all the time, even if the Isuprel rate is all the time the same, 3 micrograms per minute. And we will continue ablation with these intercable lines. And I think we may switch to the other room for CNA, and we will comment later what we did more, what we do more. Yeah.
Okay. So we should be in the other lab where Roman did this neuroablation for AV block, functional AV block in a young lady. So Roman?
So we just finished the procedure, and as you can see, we did two or three more applications in the CSOs. And we did also final check using SFOS from right and left atrium, from right and left internal jugular vein, and there is no AV block in SFOS, and also EP parameters are improved because, as you can see, can you show us parameters, EP parameters?
So this was the pacing lower from the left?
Yeah.
And yeah. Do you see this?
Can you see? Yeah?
Yes.
So there is no AV block. Can you show us?
But we also have a
this is sequence of this high frequency stimulation. This from here up to here. So before we got this very long asystole with P waves only during stimulation, and there is nothing left like that. So it's a clear endpoint of the procedure that you abolish this
so no AV
vehicle input to AV node.
Can we show the right side now?
Live screen, please.
No, live screen. This review.
Review.
Okay.
Yeah.
This. Okay. So you see that there is no AV block,
no
and
AV
during
block,
the pacing,
just junctional rhythm.
This is the last one from the right. This time from the right, and there is no.
So you pace from both sides.
No even prolongation of the PQ, right?
Yeah.
And in addition, all baseline parameters of the AV node was improved. PQ went from 186 milliseconds to 143. AVNERP went from 290 to 240, and also Vankebach point was improved from 140 beats per minute to 177 beats per minute. Obviously, SNRT was not change because we didn't touch the sinus node. And if I may do only one comment, we discussed with Roman that this procedure is actually technically very simple and it can be done in like 40 minutes. But there are many unknowns, so we need to study more. So we believe that this approach is correct for now.
Yeah, so I'm very satisfied because with Predrag we do procedure tailored especially for the patient. So we did only AV block, we denervate only AV node, but not touched the sinus node. So I think we are happy, and the patient should also be happy.
Okay, any questions for the operators?
Oh, please. Please,
microphone.
Don't sleep.
Don't sleep, yes.
Sorry.
First, thank you very much for the wonderful procedure. One single question for the ablation, the CS-OS, CS proximal. How many watts for how many seconds? Ablation index of 500 like the before, or just a little clarification, please.
Yeah, in ECAM we are doing like 30 watts. With we increase the flow to 30 mils per minute, and we are doing drugging in zigzag manner. But Roman had a slightly different approach.
Slightly different because I usually burn using 31 watts and ablation index up to 450.
And show us the PA view of the cartomap. I just want to show you that.
And can you switch on the eyes so we can show you how the catheter is placed in the CS-OS.
This is very important because here there is also a circumflex artery. We don't want to damage it, so we are pointing this catheter, red color, to be on the posterior wall.
Can we see intracardiac echo? This is
and map also maybe, or cartomap.
This is
because
not
on eyes. I'm not sure that on eyes. Yeah, we can see also here. But for those who are not familiar with eyes,
here,
and we are on the posterior part of the coronary sinus ostium, and here you can see that also we are trying to have such a position like this, to have a vector pointing posteriorly.
That's the pyramid space we were talking about. This is from left, this is from right, and this is from the below in this posterior part of coronary sinus ostium. Vessels are going down here, and so. That's you see here, fossa ovalis starts here. So the first lesion was here, the other here, and here.
And one more comment, because we are doing this vagal nerve stimulation only anatomically under fluoro, and is usually we have a very good response. But this is perfect that we have additional a tool for patients that if we have an obstacle that we can overcome it. So this is great.
Yeah, sometimes patients have valves in a jugular vein, so you cannot go there really so high with your catheter for stimulation. So if you can display vagus as shown here nicely by ultrasound, so you can pace even lower. You don't need to go so high and across this valve, in jugular vein. So that was a comment about.
Actually, the pacing catheter was real low here in this case.
Yeah, that was a comment.
Just above the valve, actually. Yeah, just above the jugular valve.
It's always okay. So much higher.
Good. Any more questions, please?
So you said that you tested vagal stimulation in patients with atrial fibrillation to check whether they are denervated after PVI. Does the response to vagal stimulation differ in patients that have syncope in real life and in those patients with PVI?
No. This is This is physiological response, you know. In all patients, you can have a very long pause.
Even you will have the same response.
Yes, I know, but my question is whether those patients with syncope have like exaggerated response. You can measure it in any way, or it's just like the on-off phenomenon?
There is no such a study I'm aware of. But,
this is
it's a functional thing. You may have one time you do, and it could be 10 seconds, could be 12 seconds, 8 seconds. So I don't think we can, even if patient has syncope, they may not have a difference in duration, but nobody studied that. But, we just wanted to stress that this test is very important because you can measure what you've done. And you can measure after every application, so you can minimize the amount of applications, the amount of ablations. You can hopefully decrease the risk of any complication if you can do it like this. Because if it's not necessary, why to ablate more? But if you only do it just because you believe that you should ablate enough in that area or that area, that's always different. So that's probably answer. Any more question? If not, I think we would like to thank you, Roman and Drag, for a nice demonstration of this neuroablation for an AV nodal functional problem. And yeah, thanks. So now we will move to lab where Dan does this modification of right atrium for inappropriate sinus tachycardia using pulse field from solid tip catheter.
Za Krista terminalis, jasně. Tady by měla být asi hladká, jo. Tady by neměla být ta trabekularizace. Tam to naskočí. We are live? So cardio neuroablation was finished, as I see there. All right, so the rest. Kdy je konec toho live caseu? V kolik hodin?
And then you are live.
All right. I just checked how many times.
Case now, okay?
So we have bit more. Nemluvte mě teď mě do toho nemluvte tak moc, jo? Já už jsem live, jako jo. So we have, let's say, 30 minutes for demonstration. The rest, now we have a problem with connection of mapping ablation catheter because it could be because of this using Centauri system. So I'm waiting until I see the icon of Navistar catheter, a Smart Touch. So there is kind of unknown error.
It's too much energy in the
Carto system. What I we did, we haven't done a lot since we have last online. You see that we started doing this first intercable line. These are like pink points going from the posterolateral SVC circle down. There are 4 deliveries, and we decided because in these parts the right atrium is not as thin as at the junction with SVC, so we decided not to deliver a single pulse of energy, but 2 pulses each of 25 amperes.
So then,
just to be sure that we are transmural.
Can you hear me? Can you hear me?
Yeah, I can.
Okay, so actually, for us to explain better. So you are saying that you apply on one side twice, right?
Yes.
Okay. So and the pulse field applications are tagged by the pink, or what is the color?
Yes.
Okay. And in the last,
so there were four deliveries, and at each side we give two pulses.
Doubled.
Yeah, exactly.
Okay. Fine. And what I understand, so you are just in the mid of the line. You want to finish, right?
Yeah, exactly.
Okay.
And now I am waiting until this error will be resolved, because I can't see the. All right. So the advice was to change the mapping catheter. Maybe there is something.
I will tell you, it's a mapping catheter issue, because the energy is sometimes not under the control. Even you have switch off the switcher. When you switching off, it's always going some energy to the catheter. This is a big problem. To the system, not to the catheter, to the system.
Dejte mě návlek. But this doubling of ablation lesions, it's completely empirical.
No, it's okay.
Nobody knows.
So you need to take,
because normally for PV isolation, the single delivery should be enough. But now we are ablating like outside the great veins area, so it's empirical decision. In VT cases, usually 3 deliveries are done. Teď už je to jedno, to tam nějak navlíkneme, jo? Nebo dejte mě hadičku ještě. Hadičku. Poslouchejte mě.
Is there anybody in the meantime? Is there anybody from Brno, from Svatana? No.
Už jsme vyhodili všechno.
They did a lot of, PV isolation using this galvanized system. And the galvanized system was really the very first system after Farapulse to went to the market with a CE mark product. But it's you need to understand, it's a generator created by the company, but it's really not tested properly, I guess. And the problem is that that catheter, I think, is gone. Oni odložili kateter, jak musí dávat nové.
Taky jsme měli modrej?
Ano.
Guys, what you should do? Discussion, please.
Unique questions. Opportunity to ask anything, not only about neuroablation, maybe.
There's a question.
In this case, we saw that there was a duplication of the sinus node. There was another focal area where the impulse came. So in this case, should we consider the only the caval isolation sufficient?
I think this is a good question. Nobody knows exactly, but the scheme which was shown by Carlo Diasmundis is exactly targets on the upper part, because if we did it, I did maybe 25 years ago first procedures for inappropriate sinus tachycardia, but with RF we were targeting during infusion of isoproterenol, we were targeting this upper part and we were ablating everything, and then you create it is temporary effect and then it comes back again. But here the concept is now to separate this upper part with minimum risk of phrenic nerve palsy, and then do ablation down across this line, which was also suggested by Carlo, to damage some inputs to SA node. So it's a completely different concept. So nobody knows exactly, but this is a key thinking behind that you separate this upper part, which is activated during isoproterenol or during sympathetic activation. From lower part, and that's responsible for a higher heart rate. But nobody knows what is inappropriate sinus tachycardia, because I remember we had some patients with very torpid, inappropriate sinus tachycardia. We ablated 5 times. We even did epicardial cryoablation, and they still recurred after a certain period of time. And then we found that they had, one lady had some antibodies against beta receptors, and so it's some kind of basket where you put everything what you don't understand. If it's not, I don't know, hyperthyroidosis, for instance, this is clear cause of inappropriate sinus tachycardia, but there might be some other causes. Nobody knows what it is, the background of this. And it was, I remember from these earlier studies, many of these patients were ladies or women who worked in healthcare or social services, which was a remarkable coincidence. I don't know, what does it mean?
Teachers.
And teachers also.
Lady teachers.
So what does it mean? I don't know. Maybe nothing, but just saying that this is a really ill-defined clinical entity, this inappropriate sinus tachycardia. So, and I must say that with drugs like ivabradine, I rarely see patients who really have severe symptoms. You can handle it. Problem with beta blocker is that most of these patients have low blood pressure, so they cannot tolerate a higher dose.
Okay.
Thank you.
Dan, did you replace the catheter?
Yeah, we replaced catheter and cable at the same time, so we don't know if it is cable or catheter, probably catheter. So we continue creating this lesion. And what else? When I saw this strong acute effects on phrenic nerves when ablating the circle around SVC, I decided we mapped like lower portion of phrenic. You see some more phrenic tags along this line that we are currently creating, and probably we do only that one line, and I will not go more anterior, because nobody knows. I wouldn't like to end up with permanent phrenic nerve damage, and if I see these, hopefully, temporary effects, we may, and it's patch, to je patch, musíte tam rozpojit znova PIU. This is like low-level problem because it should appear now. So once more, disconnect.
So again, we really don't know all answers to questions, but this is a kind of attempt to reproduce what Carlo Asmundis showed us they do with this hybrid procedure. And if it turns to be, maybe we have to use a large footprint catheter like Affera in the future, I don't know. But certainly it's worth of exploring this, because if the patient has symptoms despite the fact that he or she is treated with ivabradine and some other drugs, it's worth trying, because the risk here is much less than when we used RF. And I know one patient, for instance, from Germany, and she underwent this heavy ablation with RF, and she had vena cava superior syndrome with complete closure of vena cava. So this is believed now, based on all our experience, that this is low-risk procedure which can be attempted. We are not saying that it works, because we did few cases, but unless you do these procedures, unless you try, you never move forward. So of course, if we would just sit and do what is known, there will be no progress. Neuroablation also, it took many years. It was described in 2005, and it took about 10 years almost before it started to be a little more widespread. But and we showed here first a live case worldwide in 2015, and it was another almost 10 years. And now there are much more. There is much more knowledge about this strategy, and there are more centers adopting this strategy. So you know, it takes always time, but you have to do something. You have to work. Other questions?
There's some progress there.
Works. I have such a question. For example, if we see a young patient who received previously a pacemaker because of such neurovagal syncopes, and afterwards he received neuroablation. It's just a question in this whole.
You can explant pacemaker. That's an issue, and we have some patients who already had explanted pacemaker, because I think if somebody is young and somebody implants pacemaker, which is not rare. If you only implant pacemakers, you treat everything with implantation of pacemaker. So, and if the patient continues to have syncopes because of neurovagal origin, then you do this neuroablation and you can explant pacemaker, which for the patient is tremendous difference because of all potential complications of the leads and exchanges of the box, etc. It's also probably financially more attractive than implant pacemakers all his or her life.
So
if this is what you ask.
So it's safe enough to explant, yeah? Understand. Thank you.
The problem is the extraction of explant.
Yeah, it's better to explant after 1 year rather than after 20 years.
Okay. Then
so you see they are proceeding down to the IVC.
Well, you are finished.
And as he said, he doesn't want to go more anterior to close to the phrenic nerve to avoid some potential damage to phrenic nerve. Yeah, although we believe it's not so high risk, but you never know.
Yeah, exactly. Probably we will wait how the sinus rate behaves, because when we were ablating somewhere at this portion, I am pointing with the mapping catheter to this area, there was unexpected acceleration of sinus from 80 to 110. So I didn't understand, and I have no explanation. There is no mechanism, but it happened, but it was only temporary. It lasted maybe 2 minutes, and when we continued ablating towards the IVC, it went back to this reasonable higher heart rate of 860, 890, like just now. So I think I only check what we may check just now, if there is recovery of phrenic capture. So please rotate map to the left, just to zarotuj mapu doleva trošku. Ať vidíme se na fréniku. Pust tam 20, output of 20 amps, milliamps, not amps.
Give us fluoro.
That is still non-capture, all right.
Capture.
Fluoro, yeah, I will provide. Wait a moment, I should switch from 2 frames per minute to 10 frames at least, just to be visible. And we can't feel any movement of diaphragm, and diaphragm is up even during the artificial ventilation. No contraction. So probably the recovery will be a little bit delayed, and in such a situation, otherwise I would give if there is no this problem with phrenic, I would give one more lesion or a couple of lesions to this area I'm pointing out to. So because this is even closer to this native sinus node, which was somewhere here. This is that one lower yellow point. All right. So we believe. I think that's all from our side. Now we will stop isoprel, stop infusion, and sinus rate should. We haven't seen any junctional rhythm during procedure. We have seen this when we did our first case in November last year. It was not present in the second case. Second case in January, there was only like slowing during the procedure and no junctional rhythm. And today we also haven't seen any junctional rhythms. And the slowing was not like in sudden drops, but it was continuous while ablating around superior vena cava. And this line has this intercaval line has already no effect when I don't count with this temporary acceleration while ablating at the rather inferior portion of the line. So if there is no explanation for this. Yeah. So we will be waiting a couple of minutes after the finishing of live case just to see if there is later recovery of phrenic and if there is if there is more drop in sinus rate after stopping of isoprel infusion. It may take 20 minutes. So if you have any additional questions, we still have 15 more minutes, but you may, I don't know, it's on decision of chairmen.
In Amsterdam?
Questions?
Yeah, perfect.
Comments? No?
Okay.
Oh, there is one question here.
Just a purely ignorant question, but so you're using the Biosense catheter with the Centuri generator. Have you used it with the Biosense Webster pulse field generator as well? Do you have experience with both?
No, we don't have experience with that generator. With solid tip, you mean? Or for, which one you mean? Pulse field? No, we don't have.
Okay.
Yeah. Thank you for a nice case. You put the name an appropriate sinus tachycardia and POTS. Do you have any experience that it works really on POTS patients?
We don't, but I think
was
Carlo
mentioned. May I answer?
Yeah.
I haven't heard the lecture of Carlo Asmundis, but it was probably mentioned because as a matter of chance, when they start including all their patients for treatment of inappropriate tachycardia, they retrospectively recognized that roughly 1/4 of them, 25%, was in fact not inappropriate sinus tachycardia but POTS patients. And the clinical outcome was surprisingly the same as for patients with IST. But we have no experience. This is our third case for IST. We haven't done the procedure for POTS so far.
Thank you.
Okay, so you want to say something more, Dan, or?
No. I think we have. Yeah, there is nothing to add. We may try. If you want to close the session, we will pace the phrenic again, but I don't believe that the recovery will be so fast. So again, I will not show on X-ray, but we check start pacing.
So then
we will tell you next year. So this is the reason also why to come.
Exactly.
In the end of the session, right?
Stimulation.
Still 1 hour.
Yeah, 1 hour is still here. But if not, then next year we will tell you. So you should come to learn.
Okay.
All right. So there is still non-capture, and maybe the last lesion was half an hour ago, because also these lesions, not only this circular lesion around SVC was critical for phrenic damage. Also this intercable line, because you see that there are some phrenic nerve capture sites. Even it was with 20 milliamps with high energy and very like weak capture. This is not far, and the pulse field energy may, let's say, reach rather deep and be effective not from even when not in contact. But let's report this next year if there is recovery. Hopefully there will be, because this would be probably the first permanent phrenic lesion in the world. I can't. It was not reported in. If I remember well, it was not reported in AF. There were some only few phrenic lesions, but all these were temporary, disappearing within 1 hour, 2 hours, or up in 1 day. So hopefully it will be the same in this case.
Okay. Thank you.
Thank you very much.
Guys, as we are as well very in time, very in time, even earlier than in time. Shiv is here, next speaker. So let's make decision. So what do Peppo?
I don't know. There is a planned coffee break. So if you want to have coffee break, or if you want to continue with 2 additional lectures and then have coffee break at the end, some people can leave earlier or whatever you. What do you want?
Coffee break.
Coffee break. Great.
Great.
But can we reconvene earlier? Can we come back earlier than at 12 o'clock? So let's say 11:45.
11:45.
11:45, okay? 11:45.
Great. Good deal.